Hello folks, I'm going to start where we left off in class and take us through the next couple of slides. I've added a couple of links here just for my benefit so I can move along quickly, and I'll load these up as well as a separate slide set so you can link into them if you'd like to. So the question that we started to pose was, how good are we? And what evidence and what kind of clinical predictors should we use in terms of creating a clinical predictive model for community-acquired pneumonia versus non-pneumonia for the cause of cough and other symptoms. So I'm going to take us to one of these links. This is actually a study that was done in children, so I know that we're talking about adults here, but it was kind of a landmark study that took a look at the sensitivity and specificity of certain symptoms and predictive value, particularly crackle, tachypnea, and nasal flaring, and chest indrawing, which were the items noted on the short video, cartoon video we watched in class. In the case of children, again, these are the more predictive symptoms, and all of them having a high sensitivity with low specificity. So again, the presence of tachypnea, nasal flaring, chest indrawing, and then auscultation of crackles on the chest suggest that we can more accurately predict in children the presence of pneumonia. So we can see in this study published in 2013 that took a look at a large number of European patients with acute cough. GPs in this situation were only able to accurately diagnose by clinical symptoms pneumonias that proved to be pneumonia by radiography 29% of the time. So clearly there is a need for other indicators, other markers, and certainly chest x-ray still is held out as gold standard. Although I will mention to you as an aside that in another source I saw documentation of a comment that the clinical outcomes of the patients aren't improved by necessarily by having the chest film done. And I think that's reflected in this study where the cases that were severe were picked up. It was the less severe cases which were not picked up by clinical criteria. So chest x-ray is considered the gold standard, even though some may argue, again, clinically that it may not change outcomes. This is just a quick, nice little slide share that you might want to peek at to get you oriented to what a normal chest x-ray should look like. This is a PA view of the chest, which is the typical view. We're going to be doing a little bit more about this in later semesters, but just wanted you to take a peek. This is a nice little slide set. If you are going to get a chance to look at x-rays, this might be a good tutorial for you. And it gives you kind of all the structures that you're looking at, and then takes up, again, gives you a sense of what a normal chest x-ray looks like. Now take a look at this chest x-ray in comparison to those prior, and on this chest x-ray you can see an infiltrate in the left lower lobe. Please don't be distracted by any data up here. This was all blinded for a teaching program, so every patient's x-ray says that they were born in 1950. I believe this is a younger woman in this case, and you can see the infiltrate overshadowing the left part of the chest, and this is the PA view, and then in the lateral view, again, you see it coming across. The left heart border is obscured. I took a look as well at another study which took, again, was kind of exploring possible other testing that could be done. And you'll read in your book as well as in some of the articles about community-acquired pneumonia that people are talking about various assays to try to figure out what is the etiology, because as I said in class, we really treat this empirically. We do it more by history and what kind of patient we think we have. And so these PCR assays, this study basically said, yes, it can help us identify some of the pathogens. Real-time assays combined with diagnostic methods like bacterial cultures and urinary antigen assays, which can be used for the atypical pneumonias, can be done. But really, I think it's probably more important to understand that out of this study came the realization, which your book does reflect upon as well, that so many of the viruses are important causes of CAP and co-infections, and much more than previously thought. So in class, we were going to do a little exercise where I was going to ask you to paint a picture, if you will, etiologically of what a patient might look like who had each of these. Now you'll recognize these names, strep pneumoniae being kind of the most common cause of bacterial pneumonia, Haemophilus influenza being one of the top ones as well. We occasionally see Klebsiella. I'm going to go to a website in a second. We're going to talk about all this. M. catarrhalis, again, fairly common in there. Mycoplasma being one of your atypicals, along with Chlamydia pneumoniae and the Legionella disease. And then viral, whether it's influenza or other viruses. So in a second, we're going to go to this little page on e-medicine, which is another great resource for you to look up certain things. Just a little aside for you, Medscape, or e-medicine, Medscape, is actually a fairly useful tool. It's kind of the poor woman's, if you will, up-to-date, has a lot of great things. So this is their section on community-acquired pneumonia, and they kind of run through the basics here in this first panel, talking about the various etiology, as we already said, Haemophilus influenzae, in addition to streptococcal pneumonia, Moraxella catarrhalis, these being the common ones, as well as rhinovirus and influenza. The term typical CAP refers to bacterial pneumonia, such as these above. And again, this is the classically presented patient that we already talked about in class. Now, underlying obstructive diseases, with those patients, again, if you were going to paint a profile of someone with H. flu or MCAT, you'd probably be looking at someone who has underlying COPD. Interestingly, the recent influenza infection would lead you to think of Staphylococcal aureus, which you might say to yourself, wait a minute, staph, that's a skin infection. But in fact, that can be true, and we can have MRSA infections as well. Alcoholic patients are the ones that we worry about in terms of the current jelly sputum producing Klebsiella pneumoniae. Alcoholic patients are at high risk because of their immune status, as well as tendency for aspiration. And you'll also notice in your textbook that the anaerobes can be an etiologic factor for alcoholics or others who have swallowing difficulties and inhale something, aspirate something because of swallowing difficulties. A long list of atypical community-acquired pneumonia. Again, these patients don't look as sick or bad as those above, but this is the long list there. And again, most commonly Mycoplasma and Chlamydia. And again, there may be extrapulmonary signs and symptoms. Don't dismiss those. People may say that they have belly pain, diarrhea, and you may think that they are thinking of a GI thing, but it could be that. Here they talk about doing a whole bunch of tests, including sputums, gram stains, etc. Again, we talked in class about how hard those are to get in, especially in a community setting. And of course, they talk about radiography, and those are key parts. Skipping right along, you can either use your Sanford guide or you could use something like this outline. This kind of simplifies things very nicely. As far as the pharmacologic therapy, they talk about coverage for strep pneumonia and atypical bacterial pathogens, because again, we usually don't know what we're dealing with. So for a young, generally healthy patient, we're going to look at a macrolide such as azithromycin. Z-Pak, yes, it's true, is appropriate for this, and doxycycline as a second choice. For people with comorbidities, however, and you'll see this in your Sanford guide as well, we're really going to have to take us away from the macrolides and go into the respiratory fluoroquinolones such as moxi or levofloxacin, and or we're going to go with a beta-lactam, like a high dose amoxicillin or amoxicillin with clavinolinate, or ceftriaxone or one of the other cephalosporins, plus a macrolide or doxy. And if we have macrolide resistant strep pneumoniae, we're going to consider using the fluoroquinolones. Again, respiratory fluoroquinolones are fairly big guns, but may be necessary in these certain classes of patients. Last but not least, when we're looking at patients, we will want to evaluate them for pneumonia severity and to decide whether or not they should be in hospital or at home. So this is off of the MD Calc site. This is used for emergency department settings to decide to stratify patients into risk categories. You can see that if there's confusion, they're gonna bump up a bit. BUN, which is a sign of dehydration, elevated BUN. Respiratory rate, we talked about that already, tachypnea. And so these people are going to be watched very closely. If they become hypotensive, we're going to worry about them more. And of course, if these patients are probably going to be admitted because they're dropping their pressure probably because they're septic. And of course, over age of 65 puts them in a very high risk category, and their 30-day mortality rate is almost 30%. So we can think 30-30. If you give them an elevated BUN, they're really they're in big trouble. Now, there are others. I like looking at the pearls and pitfalls here. So we like to think about other things to consider, which would include the PaO2. And again, that respiratory rate shows up again. I just want to emphasize that for the millionth time. Vital signs are vital. So pretty good sensitivity of mortality prediction. So that's what the curve is for. It's to decide whether or not you should send the person to hospital. And it doesn't have to be used just in ER. It's great for primary care as well. So that wraps that up in terms of community-acquired pneumonia. Next week, don't forget, we have a pre-test on renal topics only in the Lesson 5 readings. Of course, you'll prepare your GI topics as well, but there's no items on the pre-test about that. And that will be our last class before our winter vacation. See you then. Thanks.